So you're a young doctor stepping into the ICU for the very first time. We all know that feeling, right? That absolute chorus of beeping alarms can trigger instant imposter syndrome. It's a hugely stressful environment, and honestly, the mechanical ventilator usually sits right at the dead center of all that anxiety. Well, let's dive into this explainer and completely demystify this machine. We're going to transform it from this intimidating, blinking black box into your ultimate clinical co-pilot. Today, we're stripping it all down to the core concepts so you can confidently manage these ventilatory modes and life-saving settings. Today, we're stripping it all down to the core concepts so you can confidently manage these ventilatory modes and life-saving settings. But hey, before we get totally lost in the weeds with the complex dials, the waveforms, and those blaring alarms, we need to take a quick step back. We really have to remember the profound and delicate physiological poetry that we're actually trying to preserve with this piece of equipment. The poet Rainer Maria Rilke called the breath an invisible poem, and that's absolutely spot on. Our goal with mechanical ventilation isn't just to aggressively blast air into a vulnerable patient. It's to protect their lungs, optimize their comfort, and give them the space to heal so they can eventually breathe that invisible poem all on their own again. To make all this totally manageable, we're going to hit 5 logical steps today. First, the goals of ventilation. Second, the language of the vent. Third, choosing the right mode. Fourth, decoding those tricky waveforms. And fifth, troubleshooting and safety.
All right, part 1, the goals of ventilation. Let's quickly establish our ground rules and figure out what exactly we are trying to accomplish before we even touch a single dial.
A really crucial trick here is to group these settings in your mind almost like a phone number. Over on one side, you've got ventilation. This is entirely about removing carbon dioxide and regulating your patient's pH. So if your blood gas shows a pH problem, you fix your ventilation settings, meaning your respiratory rate and your tidal volume. Think of a COPD patient who is dangerously retaining CO2. You focus right here to help them blow it off. Now, on the flip side, you have oxygenation. This is all about ensuring life-sustaining oxygen actually gets delivered to the tissues. Got a severe pneumonia patient struggling for air? This is where you look. If oxygenation is the issue, you adjust your FiO2, which is the fraction of inspired oxygen, and your PEEP, the positive end expiratory pressure that essentially stents those tiny alveoli open. Just keep these 2 distinct pathways clear in your head, and you're always going to know which dial to turn. Moving right along to section 2, the language of the vent. We need a foundational vocabulary to understand what the machine is actually doing during every single breath. Once you grasp these 3 words, trigger, limit, and cycle, you literally stop memorizing settings and start actually understanding physiology. Every complex mode out there is just a different mashup of these 3 variables. The trigger, that's what starts the breath. It might be a strict timer set by the machine or a drop in pressure when the patient's diaphragm makes an effort. The limit is what restricts the breath. It caps the gas delivery at a specific pressure, volume, or flow to make sure we don't cause injury. And finally, the cycle. That's what actually turns the breath off, terminating the inward flow and flipping the machine over into exhalation mode. Now, when you map those variables out over time, it flows beautifully. You have the trigger phase kicking things off and pulling the flow upward. Then comes the inspiratory phase, which is when the actual gas gets pushed into the lungs. After that, the cycle phase kicks in to terminate the inspiration, dropping the flow right back down to 0. And that seamlessly drops us into the passive expiratory phase. Understanding this 4-part rhythm is exactly how you start fluently reading the absolute matrix of data on the ventilator screen. Okay, part 3. This is the big one, choosing the right mode. This is all about how we divide up the workload between our patient and the machine. Let's look at the dichotomy between your 2 real heavy hitters, assist control, or AC, and SIMV. Think of AC as totally taking the wheel. It takes over the work of breathing to completely protect the patient. Picture this. It's 3 a.m., and you've just intubated an absolutely exhausted patient in severe respiratory failure. AC is your best friend right now. Every time the patient triggers a breath, the vent delivers a full, mandatory breath with a guaranteed volume or pressure. Total rest. SIMV, on the other hand, is your classic step-down mode. It gives mandatory breaths at a set rate, sure, but it lets the patient take their own spontaneous breaths in between, drawing whatever volume they can generate themselves. It essentially forces the patient to use their own diaphragm, which is huge for preventing muscle atrophy as they recover. Now, AC and SIMV are the historical mainstays, for sure. But as a young doctor, you're definitely going to run into a few other more nuanced modes. These ones trade guaranteed tidal volumes for better pressure management or patient comfort. First up, pressure control. This delivers a strict, set pressure for a set time. It's awesome for stiff lungs with low compliance, but since tidal volume isn't guaranteed, you really have to watch out for hypoventilation. Then you have PRVC. This is a very popular hybrid mode that targets a specific volume but adjusts the pressure dynamically. Patients find it super comfortable, but a massive warning here. It's not ideal for ARDS patients. Why? Because a patient breathing heavily might actually trick the machine into giving them less support than they desperately need. Finally, we have pressure support. This one is entirely patient-triggered, no backup rate whatsoever. Pressure support is basically your extubation test drive. It lets you know if the patient actually has the stamina to fly solo once you pull that endotracheal tube out.
Section 4. Decoding ventilator waveforms. Let's talk about the visual feedback the ventilator throws at you to ensure patient safety.
Okay, the absolutely crucial thing here is telling the peak pressure apart from the plateau pressure. Listen, as a young doctor, an inspiratory hold is basically a superpower. It's one of the best diagnostic tools you have because it physically separates the tubes from the lung tissue. So when that high-pressure alarm starts screaming at you, your very first move, press the inspiratory hold button. The peak pressure, or PIP, is totally flow-dependent. It represents resistance in the airways. We're talking the physical plastic tubes and the patient's bronchi. But the plateau pressure, or P-plat, which only reveals itself during that hold, represents the actual compliance or the stiffness of the delicate lung tissue itself. So how do you actually use this at the bedside? It's surprisingly straightforward. If you see a high peak pressure, but a totally normal plateau pressure, you've got a resistance issue. The pipes are clogged, but the lungs are fine. Think of a patient rolling over and kinking the tube, or biting down on the plastic, or maybe there's a sudden blockage from a massive mucus plug. However, if you run that inspiratory hold and see a high peak pressure and a high plateau pressure, that's a red flag for a serious compliance problem deep down in the alveoli. The lung tissue itself is stiffening. That points toward really dangerous stuff like worsening pulmonary edema, a pneumothorax, or progressing ARDS.
We've all been there, right? Seeing a patient buck the vent is honestly one of the most stressful things to witness in the ICU. The patient looks agitated, the waveforms are all over the place, and those alarms just won't stop blaring. But what's actually happening physiologically? Well, when the patient's own neural timing gets totally out of sync with what the mechanical ventilator is delivering, you get massive dyssynchrony. And this isn't just a noisy nuisance, it is highly dangerous. It severely increases their work of breathing, it can cause direct physical trauma to the lungs, and it induces profound anxiety, both for the poor patient in the bed and for you as the responding physician trying to fix it.
Which brings us to our final section, Part 5, Troubleshooting and Safety, because knowing how to take control when things go wrong is everything. When that high-pressure alarm starts going off in the unit, take a breath. Don't panic. Just run through these 3 actionable steps to systematically hunt down the root cause. Step 1. Hit your inspiratory hold button and check peak first plateau pressures. Step 2. Use that exact data to logically decide, am I dealing with a resistance problem in the tubes or a compliance problem in the lung tissue? And step 3, if the patient is crashing fast, instantly run the DOPE mnemonic.
So if there's an acute, life-threatening emergency, DOPE is your best friend for ruling out the big reversible causes. D is for dislodged or disconnected tube. O is for obstruction. Are they biting it or is there a mucus plug? P is for pneumothorax, which means a collapsed lung that might need immediate needle decompression. And E is for equipment failure. And hey, never ever forget your ultimate failsafe. If you cannot figure out what the machine is doing and your patient is desaturating, literally disconnect them from the vent and bag them manually. You instantly remove the complicated equipment from the equation and you secure their airway yourself.
So, as you step out onto the floor of the ICU, just remember that perfection is absolutely the enemy of the good. Your ultimate goal is really simple. Let the patient's real-time physiology dictate how you pilot the machine. There is no magic one mode to rule them all. You constantly have to adapt. Keep your ventilation and oxygenation dials separate in your mind, strictly respect the difference between airway resistance and lung compliance, and always be ready to troubleshoot methodically. So the next time that alarm goes off at 2 a.m., I want you to ask yourself, are you just trying to silence the numbers on a screen, or are you truly treating the human being breathing in the bed?